All right, guys. On to chapter 61, the fetal thorax. I'm going to apologize in advance because I'm home. It is 6:45 at night and my family is here. So they may be noisy, but I told them not to be, but they didn't listen. Okay, anyway, embryology of the thoracic cavity, adequacy of pulmonary development determines fetal viability. So baby's lungs don't develop, the baby cannot survive. Pulmonary immaturity less than 24 weeks. There is pulmonary immaturity at less than 24 weeks, and that makes a fetus less than 24 weeks non-viable. I have seen stories of babies being born a little before then that they were able to save, but that is generally speaking, the age of viability for a fetus is 24 weeks, the age at which they are able to live outside of the mother's womb. Thoracic cavity forms from the mesenchymal buds, and early trachea forms and penetrate masses to become lungs. Bronchi, bronchioles, alveolar ducts, and alveoli develop through multiple divisions and budding. 16 to 20 weeks, bronchi have formed. 16 to 24 weeks, air spaces and vascular structures. Greater than 24 weeks, progressive flattening of epithelial cells, lining airspace with development of air-blood barrier. All right. Fetal breathing movements. Fetal breathing movements, aspiration of fluid into lungs. Fluid half filled with fluid. Lungs are half filled with fluid derived from amniotic fluid, tracheal glands, and lungs. The fluid in the lungs at birth clears by the mouth and nose into the pulmonary capillaries, into lymphatics and pulmonary vessels. Remember, we watched that video about how the lungs are so high pressure when they're inside, when the baby is pre-birth. The lungs are a very high pressure system, thereby almost repelling the blood flow. And then at birth, that switch is flipped and that fluid is cleared, and then they become low pressure, which the blood then can flow through and circulate through the lungs to become oxygenated rather than being oxygenated by the placenta. Normal sonographic findings of the thorax, and you would always view in transverse and coronal or parasagittal planes. Normal shape and symmetry is bell-shaped, bordered by ribs at the lower margin, clavicles at the upper margin, and the diaphragm also at the lower margin. I'm sorry, let me say this one more time. My family's making noise and distracting me. The bell-shaped, bordered by the ribs on the lateral margin, clavicles upper, diaphragm lower, and the diaphragm appears as an echogenic, smooth, hypoechoic muscular margin between fetal liver or spleen and lungs. So I don't understand exactly why it says echogenic smooth, because it is hypoechoic. In fact, I've told you guys, make sure that you're not mistaking a rib shadow for the diaphragm. So it is hypoechoic, not echogenic, but it is smooth. This is a coronal view, not long, but coronal. Lungs are seen above the diaphragm. So diaphragm, lungs, heart, rib shadowing can be seen in the thoracic cavity. Okay. Thoracic size, normal sonographic characteristics, slightly smaller than the abdomen. The ratio of the thoracic circumference to abdominal circumference is consistent throughout pregnancy. Measure at the transverse plane of the 4-chamber heart view, which I don't know that that's necessarily something that you would be asked to do, maybe if you were at MFM working there, but that's not like a normal anatomic measurement that we would do. But if you were asked to do it, you would do it at the level of the four-chamber heart. Oligohydramnios, a resultant pulmonary hypoplasia, can be seen with reduction in overall thoracic size. Asphyxiating thoracic dystrophia is significant narrow diameter of the chest. Several syndromes are associated with this, such as thanatophoric dwarfism. Thanatophoric dwarfism. Proper level for chest circumference, you can see here at the level of the heart. And there is a formula that you can use. Best formula for predicting pulmonary hyperplasia is the chest area minus the heart area times 100 divided by the chest area. Thoracic position. Center mediastinum, the heart is midline and left of the in the chest. At the apex, which is the pointy part here, points towards the spleen, towards the left. The axis is rotated 45 degrees, meaning if you were to draw a line from the spine, which is here, to the abdomen, belly, like say belly button here, this axis should be roughly 45 degrees, plus or minus 20 degrees, base horizontal to the diaphragm. Detection of abnormalities may include a chest mass, pleural effusion, or cardiac malformation. So this is a much better picture. So here you see, if you drew a line from the spine to the front of the abdomen, like so, actually right here, looks like this little divot is just exactly the where you would measure to and then draw the angle. Spine is at 6 o'clock here with anterior, with the aorta anterior. So here, right here. Lung texture should be homogeneous, moderate echogenicity, early gestation, similar or less echogenic than the liver. Later, lungs become more echogenic than the liver. There you go. Here. Color Doppler can outline vascular patterns in the lungs. Ultrasound cannot be used to assess lung maturity. So, homogeneous, moderate echo texture of lung, liver, and heart. Okay. And there's the color Doppler imaging vascularity, 24-week fetus. Respiration, fetal breathing more prominent in the second and third trimesters, regularly seen by 24 weeks. Mature fetus, 1/3 of the time is practice breathing, which, by the way, comes from the central nervous system. It is a way for them to not only intake amniotic fluid into their lungs, but it's a exercising of the diaphragm. Breathing is a seesaw movement, a fetal chest or abdomen sustained for greater than or equal to 20 seconds. Remember that in a 20-minute time period. Remember that. However, I don't know that that is the guideline that MFM uses. I believe that they do 30 seconds without more than a 5-second pause. But for the purposes of the test, it's sustained for 20 seconds in a 20-minute period of time. Color flow Doppler to detect fetal breathing, fetal profile, flow from nostrils. We talked about that, how I once saw usually you can look at the kidneys, how just like how you can see the kidneys moving in an adult when they breathe. So same thing for fetus. So you could look at the diaphragm, you could look at the kidneys, or you could look at the in and out motion of the amniotic fluid through the nostrils, but why put color on if you don't need to? But it is one way that you can do it. So fetal breathing is stimulated by maternal increased sugar dose and decreased by maternal smoking. So if you ever are doing a BPP and the baby just will not move, will not breathe, will not do any of the things, if mom is not diabetic, see if she has some candy or juice or something on her that will stimulate the baby's movement. So there's that. Abnormalities of the lungs. The evaluation multiple parameters: lung texture, homogeneity, position within the position of the fetal heart within the chest, orientation of the cardiac axis. And we said 45 degrees is normal. So plus or minus 20 degrees is roughly equal to this. So 45 minus 20 would be 25, and plus 20 would be 65, but they're extending it out a little bit more, 22 to 75. Measure thoracic circumference. The measure lungs, length, area, volume, 3D ultrasound if you have access. Right lung volume slightly greater than the left, and you should see an intact diaphragm. Lung masses, fetal echocardiogram to exclude cardiac involvement. Cardiac rhythm abnormality and fetal hydrops. Pleural effusion commonly found. Lungs do not grow properly with small uterine cavity, compromising thorax. Severe oligo, chest cavity abnormally small. Balance between tracheal and airway pressure to fluid volume inadequate, or fetus unable to practice breathing movements. These are all reasons that the lungs may, or the chest may be small. Mass effect. Mass within thoracic cavity have poor effect on lung development. Heart and mediastinal structure displaced, lung compressed and destroyed. Effects lead to pulmonary hypoplasia. And nobody wants to have pulmonary hyperplasia. Those babies do not fare well. So let's just see what the book says. Pulmonary hyperplasia is caused by a decrease in the numbers of lung cells, airways, and alveoli, with the resulting decrease in organ size and weight. This reduction in lung volume leads to small, inadequately developed lungs. A decreased ratio of lung weight to body weight is a consistent method of diagnosing pulmonary hyperplasia. This condition most commonly occurs after prolonged oligo or secondary to small thoracic cavity caused by a structural or chromosomal abnormality. Causes. We just went over that. Most commonly from prolonged oligo, extreme reduction in amniotic fluid volume causes kidney abnormalities as well. IUGR, early rupture of membranes. So you need, obviously, you guys all know, baby needs lots of fluid in order for the lungs to develop properly. Masses in the thoracic cavity include pleural effusion, diaphragmatic hernia, cystic edematoid malformation of the lung, which is shortened to CAM, C-A-M, CAM, bronchopulmonary sequestration. I'm sorry, guys, can't read. Other large cysts and tumors of lung and thorax, cardiac defects, skeletal dysplasias, central nervous system disorders, chromosomal trisomies may occur with pulmonary hyperplasia. Unilateral pulmonary agenesis, or hypoplasia, mediastinal shift. Pulmonary hypoplasia prognosis, 80% death after birth. Severity depends on when this occurs within the pregnancy, severity, duration. Contributing factors are pulmonary fluid dynamics, fetal breathing movement, and hormonal influences. Sonographic finding, thoracic measurements at the level of the four-chamber heart, exclude skin and subcutaneous tissue. That is opposite of what we do when we measure the abdominal circumference. But there's thoracic circumference less than 5%. Let me see what Terry means by that. One moment. Okay, so it's here in the book, page 1409, says various measurements are used to determine the presence of pulmonary hypoplasia, including measurements, various lung measurements, estimation of lung volume, Doppler studies of the arteries, assessment of the fetal breathing. The sonographer may be able to check for pulmonary hypoplasia by measuring the thoracic circumference at the level of the four-chamber heart view, excluding the skin and subcutaneous tissues. A thoracic circumference below the 5th percentile suggests the possibility of pulmonary hypoplasia. Sonographers should understand that this measurement may not be helpful in conditions in which intrathoracic mass compresses lung tissue and yet the thoracic circumference remains normal. Things such as diaphragmatic hernia, pleural effusion, and cystic adenomatoid malformations. Sonographers should also look for finding a small echogenic lungs as they lie lateral to the cardiac chambers in the fetus with pulmonary hypoplasia. All right, let me just go back and see this one thing here. All right. So on to cystic lung masses. This is a good overview right here. Normal looks like so. Fluid collection in the lungs is hydrothorax. Cystic adenomatoid malformation. Got this solid kind of component there. Maybe it's cystic and solid. Extralobar sequestration. So you have this little piece kind of that's sequestered or off to itself, a little piece of it. Diaphragmatic hernia is where there's a little pouching or weakness, I should say, in the diaphragmatic or in the diaphragm where organs can poke through. And a bronchogenic cyst here. All right. So let's just read what this has to say. A is normal. The lungs have convex margins anterior laterally. So here, convex margins. And across the front, which you can't see, but they come out towards the chest wall. B is hydrothorax. Anechoic pleural fluid displaces the lungs away from the chest wall and compresses the lungs. So they're showing it. You can't tell, but this is supposed to be on the outside in the pleural cavity, not within the lung. Cystic adenomatoid malformation is an intrapulmonary mass of variable echogenicity, may shift the mediastinum and create hydrops. So this is within the lung. This is outside of the lung. D is bronchiopulmonary extralobar sequestration, a spherical or Triangular echogenic mass is evident in the inferior portion of the thorax or upper abdomen. Okay. So remember this, a spherical or triangular echogenic mass. Okay, diaphragmatic hernia we know about, and bronchogenetic cyst. If it causes bronchial compression, a simple cyst near the mediastinum or appearing centrally in the lung may produce a mediastinal shift. So, okay. So looking at this image, a little difficult to see it, but we've got the stomach, and then it looks like this cystic area. It says a longitudinal scan of the chest revealing a small cystic mass in the lung. Note the relationship of the stomach to the cyst. A benign bronchiogenic cyst was found after birth. In B, longitudinal scan showing a bulky non-cystic mass here in the thorax consistent with cystic adenomatoid malformation type 3. Abdominal ascites is present. It's here. You see it here up at the top. Liver here, and this is the fetal head. Okay. Pleural effusion, also known as hydrothorax, is an accumulation of fluid within the pleural cavity that may appear as an isolated lesion or secondary to multiple fetal anomalies. They're not showing us sonographically. Most common reason for a pleural effusion is pleurothoracic, pleurothorax, chylothorax, occurring as a right-sided unilateral collection of fluid secondary to a malformed thoracic duct. Hydramnios often accompanies chylothorax resulting from esophageal compression. Fetal thorax, hydrothorax can be unilateral or bilateral. When it's bilateral, it occurs about equally on the right as it does left. May result from immune or non-immune causes of what's this, hydra. The RH factor, immune or non-immune, that we learned about, congestive heart failure. Effusions may also occur in fetuses with chromosomal abnormalities like trisomies, in a fetus with cardiac mass. Other reasons can be all of these things. All right, so I would like to look up what this is. Let's see. It is an abnormal accumulation of chyle, a lipid-rich lymph, and space surrounding the lung. Okay, there we go. Well, I guess what this is saying in relationship to the stomach is so long as it's the situs is normal, it's an easy way to tell that the stomach's here, obviously. Then this is the right lung. Comparison to fluid in stomach. All right, we just went over this. So echo-free peripheral mass, peripheral, because It's in the pleura, which covers the lung. It is not in the lung. On one or both sides of the fetal heart, conforms to the thoracic cavity, often compresses lung tissue, may cause pulmonary hypoplasia, may cause shift of mediastinal structures, compression of heart, inversion of diaphragm. Lung appears to float in fluid. The pleural fluid rarely seen before 15 weeks. Look for lung, cardiac, and diaphragm lesions. Evaluate for hydrops. Alrighty. Get rid of this. I can get back to our book. Alrighty. So, kind of hoping they would show us a down a little bit.
Yeah.
Alrighty, so
Showing emotion. Yeah. Yeah.
this is an example of bilateral pleural effusion in a 23-year-old fetus. Transverse view of the biparietal pleural effusion. So it looks like that. The lung is just kind of floating. This is an example of a 26-year-old week-old fetus with huge cystic hygromas here and fetal hydrops. Ascites here may be seen surrounding the fetal liver. Sonographer should also look for the presence of pleural and pericardial effusions. So the pleural effusion prognosis is 50% mortality. Prognosis is worse with hydrops. Pulmonary hypoplasia may develop. A thoracentesis may help. Draining the lung fluid can help expand the lungs expand, and they can use the fluid for karyotyping. Here's good images of that. Solid lung masses, pulmonary sequestration. It's a supernumerary lobe of the lung separated from the normal tracheobronchial tree. So you have this little section, it's like a separate lobe that is present within the pleural lung sac, so it's intralobar, or is connected to the inferior border of the lung within its own pleural sac, extralobar. This probably develops from separate outpouching of the foregut or separation of the segment of developing lung from the tracheobronchial tree. This extra lung tissue is non-functional and receives its blood supply from systemic circulation, arterial supply from the thoracic artery, and venous drainage into the vena cava. Looks like an echo-dense solid mass, usually lower lung of the loop. Can I not say that? Usually the lower lobe of the lung, extralobar defects, left side, cone or triangular shaped hydrops, diaphragmatic hernia, gastrointestinal and lung abnormalities, hypoplasia. Intralobar is going to be spherical and a better prognosis for that. So that looks like this. This is a 23-week-old fetus with right side pulmonary sequestration, echogenic mass seen in the lower lobe of the thoracic cavity. A large pleural effusion surrounds the mass. So here we go, just like that. So then there's congenital cystic adenomatoid malformation, abbreviated CCAM, which is multicystic mass within the lung of primitive lung tissue and abnormal bronchial and bronchial-like structures. Bronchopulmonary foregut malformations may communicate with the bronchial tree, and it is unilateral. There are 3 forms. I'm going to read this from the book because I feel like it's just a little bit more easy to understand. Congenital cystic adenomatoid malformation, CCAM, is a multicystic mass within the lung consisting of primitive lung tissue and abnormal bronchial or bronchiolar-like structures. CCAM, one of the many, CCAM, one of the bronchopulmonary foregut malformations, results in an echogenic alteration in the developing lung during the first 8 to 9 gestational weeks. The lesion may involve one or more lobes of the lung or an entire lung. In rare cases, may be lateral. The malformation may communicate with the bronchial tree. The cyst within the mass may be large or small, with variable texture, may be solid, mixed, cystic in appearance. Most lesions are unilateral, do not favor either lung. 3 malformations are known in CCAM1, which is called macrocystic. 1 or more large cysts replace normal lung tissue. Single or multiple cysts measuring more than 2 centimeters and up to 10 centimeters. We'll look at that in a minute. Type 2, macrocystic with microcystic component. Lesions consist of multiple small cysts less than 1 centimeter. Type 2 lesions are associated with fetal and or chromosomal abnormalities in 25% of cases. These anomalies include renal agenesis, pulmonary abnormalities or anomalies, and diaphragmatic hernia. Type 3 microcystic malformations are characterized as bulky, large, non-cystic lesions appearing as echodense masses of the entire lung lobe. When a shift of mediastinal structures occur, lung compression may occur and hydrops may develop. Hydramnios may be observed secondary to esophageal compression, preventing normal fetal swallowing. So let's see here. We've got in A, this echogenic lung in calipers. So they've measured it in a 21-week fetus with severe hydrops. You see all the ascites in the abdomen. The opposite lung appears similar. The opposite lung appears similar in texture. Oligohydramniotes and episodes of bradycardia were evident. In B, in the same fetus, both echogenic lungs here are viewed. Laryngeal or tracheal agenesis was suspected. It is believed the excess lung fluid is manufactured by the abnormal lung. So if this baby does not have laryngeal or tracheal ways, I guess there's no way for the baby also to swallow. So fully type 1 cystic adenomatoid malformation showing multiple large cystic areas. So this is type 1 with the large cysts. Type 2, cystic areas measuring less than 1 centimeter. This mass is echogenic at the base of the thoracic cavity. Type 1, type 2. This one in the book, this must be type 3. This is type 2, macrocystic with microcystic component. multiple small cysts less than 1 centimeter. And type 3, asymmetry in lung tissue with right-sided type 3 cystic adenotoid malformation. Okay. Congenital bronchial atresia is a rare pulmonary anomaly resulting from focal obliteration of segments of bronchial lumen found in the upper left lobe. Appears as echogenic lung mass. Bronchi not visible in normal fetus. If main stem or segment bronchus have seen, it is an abnormal finding. Complex lung masses. Complex appearance is heterogeneous with both cystic and solid components. Congenital dilation of the bronchial tree may have cystic and solid characteristics. Congenital lobar emphysema, lobar overinflation of lung without destruction of alveolar septa may mimic microcystic CCAM. Laryngeal and tracheal atresia, enlarged bilateral symmetry, distended echogenic fetal lungs. Heart displaced anteriorly, trachea and bronchi fluid filled fetal ascites polyhydramnios. So normal appearance of diaphragm separating the thoracic cavity from the abdominal cavity here. Which seems odd that would just be thrown in there like that. Abnormalities of the diaphragm. Okay. So they're showing us what a normal diaphragm looks like. That's why that's in there. As we're moving on to the diaphragm. Muscular diaphragm forms 6 to 14 weeks. Gestation, primitive diaphragm intact by the 8th week. Most posterior aspects form last, thus is most commonly defective. Diaphragmatic hernia permits the abdominal organs to enter the fetal chest. Herniation of the abdominal viscera into the chest from a congenital defect in the fetal diaphragm. Most common diaphragmatic defect is posteriorly and laterally throughout the foramen of Bachtelek. Remember that name. 90% left-sided with left-sided organs entering the chest. Look for stomach and thoracic cavity, mediastinal shift to the right. May occur anterior and medial through the foramen of Morgagni. Communicate with pericardial sac. Heart may be positioned normally but have pleural fluid around it. Stomach normal in position. Defects in right side of the diaphragm with liver, gallbladder, intestines, and entering chest. Small diaphragmatic defects are difficult to diagnose. So I'm so very close to being done. 3 slides to go. So sonographic findings. Shift of heart mediastinal structures, right shift in the left-sided defects, left shift in the right-sided defects, mass in the thoracic cavity, could be liver, stomach, spleen, large bowel, and left-sided defects, or liver, gallbladder, intestine in right-sided defects, small abdominal circumference resulting from herniated abdominal structures. There's less in there, so doesn't measure as large. Obvious diaphragm defect, hydramnios, which I believe is also polyhydramnios, greater than 50% of structural anomalies or chromosomal abnormalities. I want to see if
Are you reading or responding?
I'm recording.
And then Martin's not helping, huh?
Say hi.
Like. You gotta go back now.
Okay, sorry. Told you. Family's home. Alrighty. So I want to just go back and see what Terry meant by this 50% structural anomalies or chromosomal anomalies. But it doesn't really say what the other 50% is, so I don't know. I'm hoping to find that. But abdominal circumference is less than 5th percentile, and liver in the chest indicates a poor prognosis. So here we go. And that's what it looks like sonographically. Note mediastinal shift to the right. So the heart is now over to the right side, being pushed by the liver. And this is what this looks like sonographically. And that's it. All right. Well, we got through without my dogs going too crazy. Read through the pearls and the vocabulary. All right, guys, signing off.